Hello and welcome to chapter 14. Today we're going to be discussing the brain. I'm going to be typing up additional notes here on the side, on the right side, so you guys can kind of follow along. I know listening to lectures and just staring at PowerPoints can be challenging, so I'll try and add a little extra notes on the side to help you keep track of what we're talking about. So let me just move that over a little bit. Okay. So, what does your brain do? You kind of already know this. The job of your brain is really processing information, right? If we were to summarize the job of the brain in one go, it would be processing information. So, we talked about this already. Where does it process information from? How does it do it? If you remember, you have sensory neurons that then send information to the brain. The brain then processes the information and then sends commands to the motor neurons. So this can control anything from organs to muscles to glands, that sort of thing. Okay, so moving onward, the divisions of the nervous system we've already talked about. You have a central nervous system and a peripheral. So the central, everyone knows, we've gone over this a few times in class, is the brain and the spinal cord. So that's what our lecture is going to be on today. And then the peripheral nervous system is what makes up these sensory neurons and motor neurons, all right, that are going to send that information to the central nervous system and away from the central nervous system. Right, so the functions, again, we talked about this when we learned about the 12 cranial nerves. You have sensory, right, which is, again, going to send information to the brain. And then you have motor, which is responding to commands from the brain. And then you have integrative, which is what the brain does. It's going to process everything. Neurons we already talked about. This slide is really just in here because we used to teach the brain before we taught neurons. But again, this is just a nice summary slide. All right, neurons, they are electrical and chemical pathways, right? So it has electrical components, electrical signaling, we'll say. It has chemical signaling, right? If you remember, the chemical signaling are actually the neurotransmitters, like acetylcholine, that sort of thing. And that's how really neurons communicate. And then again, they have this insulation called myelin on them. Now, the myelin is to speed up signaling, and that is essential in a lot of your neurons. And the reason we're mentioning it today is because the brain has a ton of myelin, what we call white matter, and that makes sense because your brain is made up of neurons. Okay, so this is just the overview of what we're going to be going over today. To the right here, however, this is a picture of the brain from the top of the head, as if you were looking down. Okay, so a superior view of the head. The top here is the anterior portion, so the front where the eyeballs would be, right? And this is the posterior portion where you would have the back of the head. Please don't mind the noise in the background. Okay, so what you'll notice is the different lobes of the brain are actually similar names to the bones of the skull, which kind of helps out a little bit. So these two sides are called cerebral hemispheres. You have a left and a right hemisphere, right? If you think kind of like you have a north and a south hemisphere of the globe. The frontal lobe, parietal lobe, and occipital lobe, all in the same places as are the skulls, the bones in the skull. Pardon me. Okay, so we'll move forward and just talk about the brain a little bit. So here it says the brain weighs about 3.5 pounds, just to give you a frame of reference on its size, but it actually uses up 20% of the oxygen supply, which is actually pretty significant if you think about it. You think if you weigh, on average, 150 pounds, and then maybe less, about, what is that, 2%, 2 to 3% of your body takes up 20% of your oxygen supply. Not only that, but it requires constant glucose. You can never run out of glucose for the brain, right? We talked about, especially during glucose sparing effect, the brain cannot run out of glucose. So if you're running low on it, all of it is getting sent to the brain, and the tissues are going to have to get their energy from alternative fuels. Okay, so there's three major parts: the cerebrum, the cerebellum, and the brainstem. So the cerebrum is the giant part that you're used to, right? It's this whole big round bit. Looks like the majority of the skull. The cerebellum is the back bit here. You can think the L in cerebellum for little, right? So cerebellum is the back, cerebrum is the big part. Any X-Men fans out here? Cerebro, right? Looks like the helmet, looks like the cerebrum, okay? And then, of course, the brainstem, which is this part in yellow here. It goes all the way down and meets with the spinal cord at the bottom. And we'll talk about the four parts of the brainstem a little bit later. If you recall back when we were talking about directions, you'll remember that we talked about rostral, which is toward the mouth or the front of the face. So here is where you'll tend to use that a little more often. Rostral is towards the front here. Caudal is usually towards the tail, but when you're referring to the brain, it's going to be down towards the spinal cord, right? Because the spinal cord kind of looks like a tail here. It makes more sense in animals whose spine goes back like this, whereas we stand upright, so it kind of messes with directions a little bit. Okay, so this is just a picture of the cerebrum, all right? You have this nice big area. This whole thing here is the cerebrum, right? It's the largest part of the brain. Largest part of the brain, right? This thing does just about everything. You're going to look at perception, memory, thought, judgment, voluntary motor actions. All right. It's divided into four lobes. The outside is called the cortex, as you're used to, right? Everything on the outside seems to be a cortex. But at least they're consistent. Okay, so if we go back to this picture we were talking about before, you have something called a longitudinal fissure, and that's actually, if you remember what fissure means, it means like a cut or a hole or a space. And that's this big gap in between these two things, right? It's a fissure. So the longitudinal fissure is this long, deep gap in between the hemispheres, right? And that's going to separate your two hemispheres. The gyri and sulci, these are the ridges, right? The nooks and crannies of your brain. And people get these confused a lot. So I like to think of it like if you're excited, you'll be gyrating on top of the mountain, whereas if you're sad, you'll be sulking down in the hole, right? So gyrating on a mountain or sulking down in the hole. So gyri are the ridges, the top bits, and sulci are the grooves or the deep down parts, all right? Going back. Okay, your corpus callosum is the thing that actually holds this guy together. So you have two hemispheres. You'll think of the corpus callosum kind of like the Velcro. So we talk about it, the longitudinal fissure, okay, that is the separation between the hemispheres. Whereas the corpus callosum, corpus means body, so it's a body, right? It's holding it together. Is like the Velcro of the hemispheres. Okay? So it's deeper inside here. You can't see it from this view. If you were to cut this in half, you would see it, and you will see it when we do the dissection. But it's the thing that's keeping these two hemispheres together. And actually, they say that the more integrated your corpus callosum is, or the bigger it is, the more they think that you can utilize both sides of your brain efficiently. So there's that. Again, another picture of the cerebrum. You have the frontal lobe, parietal lobe, and occipital lobe. You also have the temporal lobe down here, right? The thing that makes these little, what look like cheekbones, right? This is the temporal region. So those are the four. So you have, let's see, four lobes you can see are going to be frontal, parietal, occipital, and temporal, or temporal, however you prefer to pronounce it. All right, this is just a cut, a frontal cut, and you can see they're just coloring in so you can see the gyri and sulci here. In fact, what they're coloring in right now is the white and gray matter, and we'll talk about that in a minute. Oh, here it is right here. Okay, so your brain is made up of gray matter. You've heard of that before, right? If you've ever seen any of those cop shows, they're like, gray matter everywhere. So the gray matter is the part without myelin, right? And then the white matter, you guessed it, is the myelin, myelinated neurons. Okay, so if you can remember vaguely when we drew the neurons, right? You had the body and then the axon, right? And then the terminal buttons. Sorry, I can't really draw on word here. But if you remember, the axon is where you have the myelin sheath, right? So the myelin is coating this axon. So how the brain works is it actually organizes all your neurons into bundles. It's very, very organized. And what happens is it keeps all of the cell bodies, all the big fat parts of the neuron, together around the outer edge of your brain. Okay, so they're all around the outside edge here of your brain, this orange bit on the left. Then it bundles all the axons together, and those are all on the inside. And since the axons are covered in myelin, they're going to look white, right? So that's why you have white and gray matter. So it's, um, oops. So it's the gray matter is the neuron bodies, the part without the myelin, and then the white matter is going to be the myelinated axons. Okay. Okay, so these are the lobes that we talked about. Now, we mentioned the four lobes. There is one more that you can't actually see, and that's called the insula. You can see that here, all right? And that's hidden. It's insulated by the brain itself, all right? It's this guy inside, and you'll be able to see it when we do the brain dissection, but it doesn't really stand out a whole lot. So as far as this picture goes, you really just need to know the lobes here. You don't necessarily need to know the lateral sulcus, postcentral gyrus, that sort of thing, or the central sulcus. All right, you will see it when we do the dissection, but unfortunately, the brain, everything's kind of looks the same, so it's a little hard to tell. Now, what I do want you to know, however, are the different jobs um, of these lobes. So the frontal lobe we're going to talk about is a lot of voluntary motor functions, mood, elevation, aggression. These are things that people talk about. If you ever heard of a frontal lobotomy, right? The removal of the frontal lobe. Think about what kind of person or character you've seen on TV who's had a frontal lobotomy. They're pretty much catatonic, right? And you usually do it for people who are aggressive or whatever. They used to do it back in the day. They don't do it as frequently anymore. I don't know if they do it at all, to be honest with you. Um, and you can think of a lot of brain injuries, like concussions, where these sort of things can be affected. So, motivation, mood, social judgment, aggression, you can see all of these things from chronic brain injury to the frontal lobe. So, the frontal lobe is going to be a lot of voluntary motor function, right? So, remember what we know what motor means, as well as mood, emotion, aggression, that sort of thing. Okay, the parietal lobe is going to be a lot of sensory information. All right, unlike the frontal lobe, which is motor, the parietal is going to be a lot of sensory. All right, so it's going to help you feel things as well as taste and even some vision. Not a lot, and it's mostly saved for the occipital lobe, but maybe a little. Okay, occipital lobe, everyone seems to know for some reason, is your vision center. All right, you can actually track your uh, nerves all the way. You can actually track your optic nerve all the way back to the occipital lobe. So that's pretty cool. And the temporal lobe or temporal lobe, whichever you prefer to call it, is going to be a lot of hearing, smelling, learning, memories, that sort of thing. So hearing, smelling, learning, which makes kind of sense as far as the hearing and smelling, since that's very close to both the front of your face as well as your ear, right? And then the insula, which is the part that not a lot of people mention because it's not as visual or not as easy to visualize. All right, that's going to be about spoken language, taste, other sensory information. Okay, so there you go. You have a lot of sensory. Your frontal lobe is going to be most of your actual motor movements. Okay, everything else tends to focus on the sensory. Okay, so we tried to create a little way to remember this, and if it works for you, cool. If you come up with something better, I'm all for it because, to be honest, this is kind of weak. But okay, so Frank volunteers because he is emotional. Frank is the frontal lobe and does voluntary and emotions, right? Pete can't see well, so he feels around. Parietal, can't see well because he only does some vision, so he feels around because he's mostly sensory. Owen has great eyesight. That's the occipital lobe in the vision center. Okay. Tammy remembers hearing people think she smells. So this is going to be hearing, smelling, learning, memory. And then Insula. Isabel is from Spain and loves tasting food and learning languages. I don't know why she has to be from Spain, but there you go. Okay, so these are just going to be pictures of the different locations so you can help identify them. Frontal lobe, again, same location that the frontal lobe or the frontal bone in the skull is. All right, again, same with the parietal, the occipital, the temporal, you can see here is on the side. This is a view from the bottom, so this is where the eyes would be, right? It's right under here. See, and you're like, oh, I'm so stressed about anatomy, I'm going to rub my temporal lobe. Okay. And then the insula is this tiny little bit here. So you can see you kind of open up these bits a little and you would be able to see it. Okay, so moving on, we're going on to the cerebellum. Remember, L for little. All right, so this thing has a lot of lines in it. And what you're actually seeing are different pieces of gray matter and white matter. And again, this is an extremely small part of your body. And in fact, it's much smaller than the cerebrum, but it has, I think, what is it, twice as many? Um, yeah, it contains half of the neurons. So it contains just as many neurons in this little bit as this entire cerebrum, okay? All right, which is pretty impressive, I think. So it's pretty packed in there. There's a left and a right, just like your cerebrum, and it's connected by something called the vermis, which is kind of a gross word, but it's this thing right here. All right, that's the vermis. It's kind of V-shaped, upside down V here. Okay, so that branching I was talking about, so these white and gray matter striping, you'll see it a lot when you cut it open, and it forms these branch-like shapes. So white and okay, so shapes into branches, and that is actually called, has a name, of course, because everything does, the arbor vitae, or if you're a Latin fan, it means the tree of life. Right, which is pretty poetic because you think, okay, it looks like a tree and also gives life to your mind and your brain. Cool. So that's the cerebellum. Next slide. It's part of the posterior cranial fossa, which is a big hole kind of area in the back of the skull. If you've ever, when we look at skulls, you notice that big hole. So the spinal cord goes through that, but also the cerebellum kind of sits in it. Let's see, it takes about 10% of the brain's volume, but it contains more than half of the neurons. So it's pretty dense. Here's some pictures. You'll see it looks like this little bleb down at the bottom here. It's really cool when you cut it open. You'll be able to see that tree pattern. It's pretty neat. So the functions of the cerebellum are pretty impressive, and actually it does quite a bit. So it helps with motor coordination. So if anyone's ever told you that you have poor hand-eye coordination, you can blame your cerebellum. Okay. Evaluate sensory input like spatial perception. So again, hand-eye coordination, spatial perception, 3D objects. Timekeeping center. This is a little different than what you're thinking. It's not like, I feel like it's about 3 in the afternoon. Actually, it means predicting the movement of objects. So if someone is running and you want to throw them a ball, you want to throw them a ball where they're going to be, not where they are at the moment you see them, right? Because if someone's running and you throw a ball at that spot, they're going to be 10 feet ahead of it by the time the ball gets there, right? So it's be able to predict where something's going to be in time based on its movement, all right? So that keeps the eyes lined up with something that moves. It also helps the head, help you compensate with your head. So, you know, when they check your eyes for a concussion and they say, can you follow my eyes? Okay, the ability to follow that finger is based on your cerebellum's ability to predict the movement of the object, of the finger. Hearing is also going to be like pitch and being able to similar sounds, um, and be able to hear out similar sounds like pitch and the other word that rhymes with pitch, right? Being able to tell that someone isn't cursing you out, they're just saying that you can't sing. Okay, and then planning, scheduling tasks, and also damages can lead to emotional issues and problems with impulse control. All right, so the cerebellum has quite a variety of functions. All right, finally the brainstem. And the brainstem is made up of arguably 4 components. All right, this is the diencephalon, right? It sounds like something out of a sci-fi novel. The diencephalon, di means 2, right? N means in, cepha means brain, right? So the 2 parts in the brain. And the 2 parts in the brain are actually your thalamus and hypothalamus. And these guys make up the diencephalon, this big chunky thing right here. Then you have a midbrain, pons, and medulla oblongata, everybody's favorite from Waterboy. Okay, so I find this picture's not all that helpful. There we go. Okay, so basically what you're looking at is the diencephalon are the blue parts. All right, you have the thalamus, the hypothalamus in the front here, and then the thalamus in front is the big part, right? So this whole thing is the diencephalon, and you have one on each side, just like cranial nerves. You have a left and a right side of your brainstem. Okay, then your midbrain is this middle bit right here. It's literally in the middle of your brain. Clever. Okay, and then you have the pons, which are the big fat round bits here. And then finally the medulla oblongata. You know the shape oblong, right? It's not a circle, it's stretched out, it's oblong. There you go. And that connects to the spinal cord below. So you have the diencephalon, the midbrain, the pons, and then the medulla oblongata. Okay. So this is just showing you where everything is. Apparently it's out of order. I'm going to go back. Okay, so you have the diencephalon here, this little arched thing. Then you have the midbrain, which connects the arch bit to the bottom. Then you have the pons, the big fat pot belly, right? And then you go down, you get to the medulla oblongata. Okay. So if we're going to be going with the actual function, sorry, losing on the slides here, we're going to talk about the medulla oblongata first. So this is going to be, again, connecting with the spinal cord. This is going to regulate major vital functions. All right, breathing, blood pressure, heart rate. This guy's important for your survival, right? You do not want to damage the medulla. Here's just a few ideas of what it does. All right, cardiac center, vasomotor. So vaso meaning vessel, motor meaning movement. So blood vessel movement or constriction. Respiratory centers, reflexes like coughing, sneezing, swallowing, vomiting. You can see how someone who has damaged the medulla oblongata might have an issue with survival here, right? All of these things are pretty essential. All right, so here it is from a bottom view. You can see this little bit right here, and then the spinal cord right below it. Okay, there you go, another little picture. So a little closer up view, you'll be able to see this when we do the dissection. Actually, it's really easy to find because you'll see this X on the bottom of the brain, and that'll point you right to it. And the X is actually your optic chiasma. It's where your optic nerves cross. Okay, so you have the diencephalon here, midbrain again. This picture is just showing you where the different cranial nerves come out, and you don't need to memorize this. The only cranial nerve I require you to be able to identify on the brain is this guy right here, all right? You need to be able to tell where the optic chiasma is. That is it. So moving on, we're going to go to the pons. Remember I said the pons is the big round bit in the middle. All right, I always think it looks kind of like a pot belly. but if that helps you remember it, cool. So it's this guy right here, and the pons plays a pretty important role as well. So pons, like puente, literally means bridge, all right, and it's because it's a bridge between the midbrain and the medulla oblongata. Yeah, clever, I know. It has both sensory and motor neuron tracts, and it's also the site of 4 cranial nerves. So, um, all right, so a lot of sensory motor neurons move through the pons. There we go. All right, now before we get too deep into, we'll go into the midbrain, but before we talk too much about it, what I want to mention is the reticular formation. And the reticular formation is a set of, is a network basically of gray matter. So if you remember what gray matter is, that is neuronal bodies, right, or unmyelinated neurons, either one. And it's this web that connects all parts of the brain. And you could see why that would be beneficial, right? If this part of the brain is seeing something, you want this part of the brain to tell you to move out of the way, right? So keeping everyone connected, like brain social media, helps everyone to integrate function with senses. So if you're seeing something, you're going to be able to respond to it. You can see and hear something and pull that information together to figure out where it is. So this thing is going to basically connect all the sensory and motor motor functions together. All right, so that's really important. It's going to affect sleep and consciousness. It's going to affect somatic motor control. Remember, somatic means skeletal muscle. Motor means movement. Okay, so posture, cardiovascular control, pain, habituation, which is actually pretty interesting, but you guys have all experienced this before. It's when you learn to ignore something repetitive. So if you grow up and there's a noise around your house that you get used to, right? I grew up down the street from a firing range, and we completely got habituated to the sound of the firing range. We didn't even hear it after a while. So it's your brain's ability to ignore these repetitive stimuli when you're used to them. Okay, so the diencephalon, again, going back up here, this is going to be the thalamus and hypothalamus. And it breaks it up. So the hypothalamus is the part in the front. And if you remember, I can't really see it, but there's a little pituitary hanging right off there, right? So the hypothalamus and pituitary, they're the hormone centers, right? Where the thalamus back here is just the back half of that. Don't worry about exactly every little thing it does. But the, so the thalamus is ovoid mass part. Okay, it's the gateway to the cerebral cortex. So the idea here is there are a lot of neurons and signal that go in and out, and they have to do it through the thalamus. So you know how a neuron has to send a signal to another neuron, and then another neuron, and so on and so forth. A lot of them connect at the thalamus, okay? So it's a connection point for many neurons. All right? And that way it's able to filter the information and send it to the right part. So it's kind of like the triage of the brain. So information comes in, the thalamus decides where it's going to go. Right? So there you go. Important to note, this space right here, this odd shape where it's all black, those are something called ventricles in your brain. They are basically rivers of cerebral spinal fluid that are there to nourish the brain. And this is important because the thalamus and hypothalamus form the walls of these rivers, of part of one of the rivers. And so just keep an eye on the picture. You can see that there's the thalamus there. Okay, the hypothalamus, you should all know what it does, right? We talked about this, and we talked about it, and we talked about it. Okay, hormones, right? That's like the major job is the endocrine system. It also controls a lot of the autonomic nervous system, which we'll be talking about later. Autonomic, think automatic. So things that are automatically regulated, you can thank the hypothalamus, most likely. The other thing here is it forms the part of the wall of the third ventricle. So remember we went back to this picture here, how the thalamus is forming the wall of this ventricle. The hypothalamus also forms the wall of a ventricle. Okay, so here are all the jobs of the hypothalamus. You're all familiar with them, right? Hormones, autonomic, thermoregulation, I can go on and on. Okay, so here's the hypothalamus, little doohickey. All right, and then you have the pituitary gland hanging on here. The pituitary is actually not part of the brainstem, but it's actually important to the hypothalamus, right? And we call that the master gland. This is because while the hypothalamus controls the pituitary gland controls everything else with its hormones, right? So that's why the pituitary is actually called the master gland. All right, the pineal gland, you'll remember, it's a little tiny guy. This you can thank for your melatonin. Okay, I know all of you are like, oh, I thought we were done with hormones. We're not. All right, this little P behind the thalamus, there you go. So that's going to be circadian rhythm, melatonin. Median section of the brain, this is just a nice little slice. So you can see here, this is the pituitary gland. Above that is the hypothalamus, and then the thalamus. Okay, it's kind of hard to see it, to be honest with you. It's not very well laid out. Oh, sorry, this one's a different picture. Okay, so pituitary, thalamus, hypothalamus, and then thalamus. Then, as you drop down, you've got the midbrain here. Then you've got the big pot belly pons, and then the medulla oblongata. And here, actually, you can see the tree of life in the cerebellum. You see that little branching? Isn't it cute? It's just adorable. Here's a picture of the corpus callosum, actually. So we've sliced through the longitudinal fissure, okay? And this is the corpus callosum holding together the two sides. So this is one half of the Velcro. It'll be pretty cool when we dissect it. All right, here's a picture. So here's your corpus callosum. Here's the pons to give you some frame of reference. And then you can see thalamus, hypothalamus, cerebellum, brainstem, medulla. All right, this is just another picture labeled. Okay, so we've talked about the structure of the brain overall. The next thing we're going to talk about is the meninges. And the meninges are actually what cover your brain. So these are the connective tissue membranes, right? So if you've ever heard of meningitis, here you go. If you've ever heard of an epidural, they're talking about above the dura mater, okay? So it's giving you a location based on the meninges. So you actually have 3 specific layers covering your brain and spinal cord, and they have 3 names because they're so clever. The dura mater, arachnoid mater, and pia mater. And if you go from the inner out, you get pad, right? They pad your brain. The dura mater is extremely tough. Dura, like durable. Dura means hard and tough, okay? This is like glued onto the inside of your skull, right? So this is extremely tough, and it's just going to keep your brain kind of still. The arachnoid mater is actually going to be in between the pia mater and dura mater, and they call it arachnoid, like spider, like arachnid, right? Because it's got kind of a thin white spider web kind of look to it when you see it. And this is where a lot of your fluid is going to be, right? So a lot of your cerebral spinal fluid. Okay, and then finally, your pia mater. This thing is like super thin plastic wrap over top of your brain. It even goes into nooks and crannies, right? The sulci and gyri. So this is really thin and it's really hard to see, but you will be able to separate it from the brain. Okay, so let's see if we got a good picture here. All right, here we go. So if we do the skull here, and then the next one is the dura mater, you'll see it's really tough. It's actually made of 2 layers. You don't need to know the names of the layers, but just the dura mater here. Then the arachnoid mater, you can see how that is actually kind of spiderwebby looking, right? And there'll be fluid in here to kind of nourish the brain. And then finally, the pia mater is, you can see the difference here. It's a really, really thin layer of connective tissue, and it goes down all the way into the grooves. Okay, so this is what actually gets inflamed during meningitis and what can put pressure on the brain and cause serious brain injury. Okay, so this is just some pictures of the different coverings. This one looks like the dura mater. Now if you take that layer back, you're going to see the arachnoid mater or pia mater. I can't tell from this angle, but you can just see the different layers of meninges. Okay. So the cranial meninges, the reason I wanted to show you this is that you can actually see that it's not just on the brain, but it goes down around the spinal cord too. Okay, so your brain and spinal cord are pretty much connected. Yes, good, hopefully. Um, and so the meninges are there to protect the spinal cord as well. That's why if you get an infection in your brain, you can do a spinal tap and see if there's an infection because um, they share the same meninges and they share the same cerebral spinal fluid, hence the name. Okay, meningitis. So meningitis is going to be inflammation of the meninges, right? Itis, meningitis. Cool. It can be bacterial, viral, even fungal, and it usually gets into the CNS by the nose or throat. It's really difficult to get into the CNS. And in fact, meningitis is very contagious because once it's able to get in, it's able to infect you, right? Um, Viral meningitis in general is not, it can be dangerous. It's usually self-eliminating, which means it runs its course. And the most they can really do is make you comfortable while it's running, while you're sick, and then you get better. Now, bacterial meningitis is different because bacterial meningitis, the bacteria continue to grow, and your body has a lot of trouble fighting that. And as a result, you really need to be hospitalized pretty quickly. You can cause swelling on the brain, enlarged ventricles, those rivers in the brain. What happens is the fluid fills up in the brain, and as it does that, it floods into the tissue and will basically squish the tissue and kill the neurons there, right? It can also lead to hemorrhaging. So when you talk about bacterial meningitis, usually the signs are going to be a bad fever, stiff neck, drowsiness, and then a really bad headache. And we're not talking about your normal, like, oh, I have a stiff neck and a fever, I got the flu. You will tell the difference. It's really bad. A lot of people think it's a migraine, and then it continues to get worse. I give the example, my husband actually got bacterial meningitis, and what happened is he was having the worst migraine of his life, basically. He never gets migraines, and he was just feeling really in a lot of pain. He went to the doctor and told them, like, I'm in a lot of pain, and he didn't know if it was a caffeine headache or dehydrated, so he tried all these things. They gave him migraine medicine. It didn't get better, kept getting worse. It got to the point where it hurt so bad for him to breathe because it would move his head, and when his head moved, he would get this intense pain. You also continue on to get light sensitivity, and the pain continues to get worse and worse, and you just want to fall asleep. And that's the worst thing you can do. Do not fall asleep with meningitis. I cannot say that enough. Do not fall asleep, because if you fall asleep, you're going to wake up and the bacterial infection is going to have gone much worse in that amount of time, right? Bacteria grow very quickly. So you can progress to coma and death within hours of onset. It is said that bacterial meningitis, um, if you have not sought treatment or found treatment within 72 hours, I believe the percentage is 90% fatal. So you really need to take care with this one. And again, it is severe enough that you will be able to tell you have to go to the hospital. It's extremely painful. That being said, the only way they can prove it is through a spinal tap or a lumbar puncture, where they're going to draw fluid from the subarachnoid space, right? Subarachnoid. Let's go back. Wait a minute. What's the arachnoid? Yeah, it's this bit. Remember we said it's the part filled with fluid? So they're going to insert the needle, not in your brain, but if this were your spine, right? Under here, and they're going to take up some of that fluid, right? And they're going to test the fluid to see if there's any bacteria in it. Okay. They'll usually do that between your two lumbar vertebrae, usually around L4 or L5. And they'll test for bacteria, and if it's present, congratulations, you've got bacterial meningitis. Okay, so on to brain ventricles. We talked about this a little. These are the rivers of your brain, right? This is how the cerebral spinal fluid moves in and out of your brain. And the whole point of the cerebral spinal fluid is to fill it with nutrients, right? Fill the brain with nutrients and take away any waste products. So it's just a nice, refreshing bath for the brain. These guys are labeled really nicely, okay? Remember, okay, so you've got, I don't know what's happening. You've got the two lateral ventricles here, right? So one lateral, two lateral. These C-shaped things are the lateral ventricles. So that was two, right? This part in the middle, this part, third lateral ventricle. And then fourth lateral ventricle, right? So not lateral, pardon me. Lateral 1, lateral 2, and then 3, 4 ventricles. Okay. So here's a picture of it. You will be able to see this when we cut it open. It's pretty neat. You can actually see the holes of the lateral ventricles, right? They go through the brain. You also have a cerebral aqueduct is what it's called. So if you know what an aqueduct is, pretty sure it's spelled that way, but we'll find out. Cerebral aqueduct is basically just a river or waterway. All right, so we already went through the optic nerves, and I'm pretty sure the rest of this lecture is on the cranial nerves. So congratulations. You are currently done with the brain. Nice job, guys. So what we went over, just to recap, I'm going to go through it real quick. Okay. Where is it? Here we go. So we talked about the overview of the structure of the brain, the different lobes, okay? The meninges, the ventricles, which are the rivers of the brain, right? Cerebral spinal fluid and blood supply. And then the hindbrain and midbrain. So that is basically when they're saying hindbrain and midbrain, they're talking about the brainstem, okay? And then, of course, the integrative functions. So what we're going to do now is we're going to stop with the brain and we're going to move on to the spinal cord. Yay! This is a relatively short lecture. And basically, we're just going to go over some structures of the spinal cord so you get familiar with it. And we'll just keep cracking along. Feel free to take a break if you like. I'm not here to stop you. Okay, so moving on to the spinal cord. We have the spinal cord, the nerves coming off of it, and then we're going to talk about some somatic reflexes. So what does somatic mean again? Somatic equals skeletal muscles, right? So anytime you're talking about reflexes and you say somatic, you mean reflexes of skeletal muscles. Cool. Let's keep on going. This is your spinal cord, the orange bit. What you may notice is, where'd it go? There's nothing down here. The spinal column, the spinal cord stops at L1. All right, so lumbar vertebrae 1, which is why when you do lumbar punctures, you do it down here. Yeah, we do lumbar punctures down here. Why? So we don't paralyze anybody. Okay, so lumbar punctures are going to be below L1. Right, kind of makes sense. Cool. All right. So the spinal cord is a cylinder of nervous tissue that arises from the brainstem and the skull. You know what the spinal cord is, right? It's a lot of neurons, and it's the It's everything from the sensory neurons going up to the brain and the motor neurons going down to the body, right? So that is your spinal cord in a nutshell. Okay, so thousands of Americans are paralyzed each year by spinal cord injuries. The spinal cord is the information highway which connects the brain to the lower body. Brilliant stuff, guys, right? Riveting. You know this. So we talk about damage to the spinal cord, and we have paraplegia and quadriplegia. So paraplegia is paralysis of the lower limbs, like a pair of your limbs are unable to move, right? So paraplegia is your bottom two limbs. Quadriplegia is all four limbs. Okay. When you talk about quadriplegia, um, or even any of the higher up paraplegias, you have to be concerned about respiratory paralysis. Um, all right, so respiratory paralysis can be affected if you have a damage in the cervical region, and that is pretty serious. You can also lose control of your bladder, your bowels, and even sexual function. Remember, these are sensory and motor. So not only can you lose feeling, but you can lose motor function too, right? And then the last one is hemiplegia. If you know what hemi means, it's like hemisphere, right? It means half. So it's paralysis of half the body, and you can get this, okay, from strokes, that sort of thing. So half of the body is paralyzed. Okay, so functions of the spinal cord are going to be conduction, which just means things move up and down it, right? It's like a highway. So conduction, it's like a highway of information. Okay, neural integration, they receive input, integrate it, and appropriate output. If you, when we talk about it in AP2 next semester, you'll learn that there's reflexes that don't involve the brain at all. In fact, they just involve the spinal cord. So the information will be sent to the spinal cord. The spinal cord will decide what to do and then send information right back, such as in bladder control, that feeling when you need to pee, that's your spinal cord working. Doesn't even have to go all the way up to your brain. Okay, so that's neural integration. So info processing. Locomotion. Come on, you know that one, right? It's movement. It helps you stand and walk and integrate a lot of different muscles at the same time so you can do all those things without looking like a doofus, right? And then, of course, reflexes like we talked about. Involuntary responses. Yay! Okay, so surface anatomy, just real quick. If you remember, when we looked at the spinal column in bones, we saw that there was something called the vertebral foramen, right? This is the it forms the vertebral canal. And that's going to be where the spinal cord passes through. All right, so here they're showing the spinal cord moving through, yay. And then you get these branches out to different parts of the body. Why would you need to branch out? Right, because if the information and all the neurons just stayed in here, you wouldn't have any neurons out here. So the way for it to get to the PNS is to actually leave the CNS. Okay? So here you have what's called peripheral nerves, or spinal pairs of spinal nerves, all right? And you get 31 because they branch out in between each one. All right, so you have spinal nerves branching out of the canal. Okay, so you have three major regions of the spinal column. You have cervical, thoracic, and lumbar, right? Very familiar, yes? Then it goes to another one, sacral, also familiar. Unfortunately, not actually in the sacrum, but at least it goes in the same order, right? And then the coccygeal, again, not in the coccyx, but at least it's in the same order. Okay, so spinal cord injuries commonly result from fractures of the vertebrae C5 to C6, but never L3 to L5. Why? Ooh. Okay, here's why. It's basically saying that spinal cord injuries commonly happen up here at the neck. However, they don't happen down here. And why is that? Well, one, your neck is very vulnerable to breaking, and two, the spinal cord is actually present here, whereas you do not have spinal cord down in L3 to L5. See that? No spinal cord. Right? Tricky little question there. Okay, you have these lumpier bits of your spinal column. If you look, you can see how it kind of gets fatter and then thinner and then fatter again. These are the cervical and lumbar enlargements. All right, and these guys, are going to be responsible for your limbs. So this is where a lot of neurons are going to branch out to go to your arms. This is where a lot of neurons are going to branch out to go down to your legs. Okay, so they're important for your limbs, which is why they're a little bit larger. Okay, so what is actually below L1? There are actually neurons present, but it's just not technically spinal cord. It's a different structure. So below, let's see, let me write it again. You have cervical, thoracic, lumbar, sacral, and coccygeal. Okay, below that, right, this is the end of your spinal cord, right? Then you have something called the medullary cone. Okay, that's this little triangle thing right here. Tapers to a little point. And then you have something called the cauda equina. Cauda means tail. Equina, what do you think it means? Horse, right. So it literally means horsetail, and it's because it's kind of like bundles of nerves, right? You can see them coming out here. And this is going to be from L2 to S5. It's going to be all the way down. Okay. All right, cool. So if we were to look at the actual structure of the spinal cord, you remember we have the meninges. So what are the meninges? It's the coating, right? These are the covering. So you have the pia mater, this pink part here, the arachnoid mater, right? The blue part. It's also going to be where the cerebral spinal fluid is. And then the dura mater, okay? And then you have fat in this epidural space. Now the fat is kind of a cushioning and protectant, right? You notice it's an epidural, right? Like above the dura mater. Are we tracking here? So epidural, when you give someone epidural, that's literally where you're injecting the anesthetic, okay? Above the dura mater. Cool, huh? All right. So we talked about those. Let's move a little bit forward. So the epidural space, we talked about it, is going to be above the dura mater, okay? The subarachnoid space is going to be where? All the way down at the bottom. All right, you don't want to, oh, I'm sorry. Subarachnoid space is going to be below the arachnoid mater, but above the pia mater, right? So it's where all this liquid is. And you're going to want to do that where this giant spinal cord is not present. So you're going to want to give it all the way at the bottom of the spinal column. Lumbar puncture, right? So that way you don't stab any spinal cord. So the epidural is a little different. That's given a little bit higher because you're not going in as deep, so it's not as big of a risk of damaging the spinal column. And then subarachnoid space is going to be for lumbar punctures, where you're taking fluid out. Because if we focus on it, right? If you look, if you are giving an epidural, you're only going in here, okay? That is not nearly as deep. However, if you need fluid, you're going to go down into this, and you have a much better chance of possibly hitting the spinal cord, which is why it's more dangerous. So the epidural you can do where there's spinal cord present. It's a little bit safer. The spinal tap you're going to want to do very low in the lumbar region below the spinal column. All right? Cool. All right, so spina bifida. If we go back to this picture here, right, we're talking about the cauda equina, that area. this is where spina bifida can occur, and it doesn't occur as commonly anymore, and we'll talk about why. So spina bifida is a congenital defect, all right, which means you're born with it, where your vertebrae don't actually fuse together. So if you remember, the vertebrae form this little like triangle shape with the spike at the top. Well, they fuse that way while you're developing. And so if that doesn't happen, what you're left with is kind of like an open pocket holding your neurons in, and that's not great. So 1 out of 1,000 babies is still born with spina bifida. It's in the lumbosacral region, so the lower portion of the body. And it's due to low levels of folic acid, okay? And this is why they always say, okay, folic acid if you're trying to conceive. What the problem is, though, is that for folic acid, you actually need it at high levels for the first 4 weeks of development. And if you remember, when is it that you usually figure out you're actually pregnant? Not within the first 4 weeks, right? So that was one of the challenges, is that women who didn't plan on being pregnant, found themselves pregnant, didn't have enough folic acid during that time period, and their children were born with spina bifida. As a result, now we supplement a lot of flour with folic acid. So a lot of our baking flour that we use to make breads, cereal, that sort of thing has folic acid in it. So we're not as at big of a risk of developing babies with spina bifida. Still good to take your prenatals though if you're planning. Okay, so we talked about the spinal cord, we talked about the brain having white and gray matter. And if we'll go back up here in our notes, right? Did I put it? So the gray matter was the neuron bodies, right? And the white matter was the myelinated axon, okay? And if you remember, the gray matter on your brain was on the outside, right? That's why we always talk about gray matter and the brain, because it's on the outside. We can see it more easily. In the spinal column, however, it's the other way around. So the spinal column, you'll see the white matter is actually on the outside and the gray's on the inside. Now, why would that be? Well, let me tell you. Okay, so what's happening is you actually have the bodies of the neurons here, and then the axons trail out. They also trail up the spinal column and down the spinal column. And this is where the cell bodies sit. So it makes more sense because there's more movement in different directions, whereas the brain, most information's going to the end and going inward and down. Here, all the information's in here and going out. Okay, so the gray matter here is on the inside, the cell body, the axons are on the out. Cool. All right, so going a little closer, you can see again dura mater, arachnoid mater, pia mater. You can see the gray matter on the inside here, and you can see the white matter on the outside. You also have the spinal nerves branching off. Okay, so let's see. So the tracks of the spinal column are actually extremely organized, and I was a little surprised about this when I first learned it a few years ago, because I always I don't know why I assumed it was just a giant ball of neurons, right? You just don't think of your brain and spinal column being this organized, but in fact they are. And one side is going to be your sensory side, and one side is going to be your motor, which is why it's possible to damage your spinal column and only have an effect on your sensory input and not your motor output, right? So the tracks are bundled together in organization. So remember we said sensory goes up to the brain, right? So that's going to be your ascending track, right? And that's going to be this side right here. Yay, sensory. Then you have your descending track, your motor, which is where it goes down to the body, to the muscles. That's your descending. And you can see in green where that would be on either side, right? So you have the descending tracks. So you have ones going up to the brain and then down from the brain to the body. All right, so sensory versus motor, cool beans. Now, decussation is a really cool fancy term to impress your friends. Decussation pretty much means that the nerves go from one side of the body to the other. And what we mean by that is, when someone has a stroke and it affects the opposite side the stroke is on, right? That's because the neurons it's affecting in the brain decussate to the opposite side of the body. Okay? So you have contralateral. Contra means opposite or against. Lateral means side, so opposite sides. So contralateral means the starting place of the neuron. So the neuron starts on one side and switches to the other side. All right, and this is what you're going to see in spinal nerves. Ipsilateral is when it stays on the same side. Right, this is the cranial nerves we talked about. Right, Bell's palsy. Forgive my spelling. Right, where the neuron is going to affect the side it's actually on. So that's going to be your cranial nerves. That's your ipsilateral. Contralateral is the one more people are familiar with in strokes, where you have a stroke on the left side of your brain and your right side of your body is affected. That's contralateral. Okay? And literally, the neurons switch sides. So it travels from one side to the other side of the body. Okay. So going back to ascending and descending track, let's just go up here and add it in. I know all you guys taking notes are gonna be so mad at me. There's 3 steps for ascending to the brain. Okay, and you can think of this as like going upstairs is more difficult than going downstairs, right? It's 3 steps up, but to get down it's only 2 steps. Cool. So you have sensory, which is going to the brain. So say you touch something hot. Okay, like we always give that example. So you're going to have a first order neuron, and that first order neuron is going to go from your hand to the spinal column, right? From body to spinal column. Second order neuron is going to go from the column to the thalamus. Do you remember we said that was like a connector? Okay. Now this is where it switches sides. Or decussates, right? Fancy. All right, and then you have a third neuron that goes from thalamus to opposite side of the cerebrum. Okay, so we start off here. We go 1 to the spinal column, 2 to, well, this is showing the medulla, but the brainstem, okay? And then 3 all the way up here to the opposite side. So see how it was, I don't know, it's the patient's right hand that they burned, and you'll see that it goes up to the left side of the brain. Does that make sense? Cool. So you'll see it's the opposite. Now, for motor, it's easier going downhill. There's only 2 steps. You're going to laugh. It's called the upper and lower motor neuron. So the upper one is going to be the one towards the brain that goes downhill. All right, so this is going to go motor neuron, brain to spinal cord. Cool. And then lower is going to be spinal cord to body. Easy peasy, right? To the target muscle or organ. Right? And again, you'll see it switches sides, right? Boom. Other side. Cool. So, with all this decussation talk, why would a stroke on the left side of the body cause paralysis in the limbs of the right? The answer being because the neurons are contralateral. They switch sides in the thalamus. So, if it's switching sides, it's going to affect the opposite side of the body. Okay, just about through. I'm going to talk about the nerves and ganglia. All right, we already said this last when we talked about neurons, but nerve is a bundle of axons. right? And the ganglion is a bundle of the cell bodies, or somas. So the big fat bits are the ganglion, and the nerves are the bundles of the axons, or the cables. Okay. I thought I had a better picture, but here you can actually see it. So this lump right here coming out, that would be considered a ganglion. All right. And then these thin wires, these would be considered the nerves. All right. So for further branching out, all right. Not the best picture, but there you have it. So remember, neurons are one cell. Nerves are bundles of axons. It's easy to get them mixed up because we tend to use them interchangeably, but if you're being technical, there it is. Okay, the spinal nerves we mentioned before, you have 31 pair. So it's almost the same as the spinal column bones, right? Because before we said how many vertebrae do you have in your spinal column? You have 7 cervical, 12 thoracic, and 5 lumbar, right? When do you eat breakfast, lunch, and dinner? 7, 12, and 5. Well, that's for the vertebrae, right, the bones. For the spinal nerves, it's more, right? It's 8 o'clock. So maybe spinal nerves are on the weekend. You wake up at 8 instead. So 8 in the cervical, 12 in the thoracic, 5 in the lumbar, 5 in the sacral, and 1 in the coccygeal. Okay. So similar, the 7, 12, and 5, and the sacral's 5, 4, right? Spinal nerves here is 8, 12, 5, 5, and 1. Okay. So we talk about directions again. We'll go back up. The dorsal root is sensory. The ventral root is motor. Okay, so we go back up. Motor is, I don't know, they just keep adding, right? The dorsal root and the ventral root, sensory. So, have you ever heard of dorsal root ganglia? Maybe you have, maybe you haven't. It's a very common term because a lot of viruses will sit in there, like the virus that causes shingles, right? Will sit in your dorsal root ganglion, right? The dorsal root, motor neurons, the cell bodies, and it'll activate later on in life. So here are the pairs. Remember, these are in pairs as well, just like in the brain. Nerves are always in pairs because you have left and right side. Okay, it's a really good picture of a spinal cord. Remind me in class, we do have a cow spinal column we can look at. All right. We talk about the word plexus. You may have heard this before. A plexus is a branching network of spinal nerves. Okay. And the plexus, or the plexi you need to know, is the cervical, brachial, lumbar, sacral, and coccygeal. All right. So the only difference here is instead of thoracic, they call it brachial. But you'll see the plexus are actually, instead of coming straight off as individual nerves, what they're doing here is they're kind of merging and making this net kind of shape, right? And they're doing it here as well, and again here, and again here, you get that net shape. So this is just a little image of what each one contains. Cervical nerve is really important because it contains the phrenic nerve, the cervical plexus, sorry. Okay, the phrenic nerve is going to control your diaphragm. So if you damage your phrenic nerve, you're not going to be able to breathe because your diaphragm cannot be controlled by you anymore. Right? So the phrenic nerve is something really important when they look at cervical injuries to say, okay, well, you've damaged your neck. Let's make sure that the cervical nerve is not, the cervical plexus is not affected, or the phrenic nerve is still intact. Okay, the brachial nerve, you can end up with carpal tunnel. Lumbar is pretty straightforward. There's not actually a lot branching off of that. And then, oops, come back. The sacral and coccygeal, a lot of people know because they have sciatic pain. And this is where the sciatic nerve sits. Okay? Oh, there you go, that little branching right there. Okay, so the other thing we're going to talk about is actually, go back. What's going on? Anyway, is the skin innervation. And this is really important because it can affect how you feel your tissue, right? So your skin is innervated. You can feel someone touches your arm. You can feel someone touches your face, right? So your spinal column actually innervates all over your body in these overlapping areas. So for instance, T1, so thoracic spinal nerve 1 is going to cover this area here that's colored in for T1 on each side, right? So you know if you lose feeling in that area, you most likely damaged the spinal nerve at T1, okay? This is called a dermatome. These individual areas are dermatomes. So dermatome equals skin areas, okay, innervated by specific spinal nerves. A dermatome map is this picture you're looking at right here, okay? What's important to know is there are overlaps, okay? So L2, yes, covers this area, but L1 and L3 cover halfway over it as well. So if you wanted to do surgery at the skin area right here, you're going to want to numb L1, L2, and L3 to make sure you get complete numbness on L2. So there's 50% overlap, which is important. Why would you want 50% overlap? You want it so you have some redundancy, right? Some backup coverage. If you damage part of your spine and it affects your ability to feel L2, luckily L1 and L3 might be able to compensate for you. However, this is actually an interesting story. My dad actually cannot feel this area of his leg, and he actually has a herniated disc that's putting pressure on L2 and L3. So he's actually numb right on the top of his thigh, just on the one side, right? Because it's just to the spinal nerve, not the entire spinal column. Okay, but the reason we went over this is because it's important when you're doing numbing surgeries, right? You want to make sure that you cover the overlapping regions. Otherwise, you're going to have someone in severe pain because it's not just one nerve that innervates this area. Okay, shingles, everyone's least favorite, right? So shingles is actually caused by the chickenpox virus. And what happens is when you get chickenpox, the chickenpox infects your whole body, including your neurons. And it just so happens that the virus, called the varicella zoster virus, okay, manages to worm its way into your neurons and kind of sit there quietly in the neuronal bodies. Okay, so the varicella zoster virus has to infect your body first. All right, that is chickenpox. That's when you have chickenpox. If you don't get chickenpox, you haven't been infected with the virus, right? Then it continues to infect your neurons as you're sick. You don't realize it, right? And becomes latent or hidden inside the neuronal bodies or soma, right? So the big fat parts of a neuron, the big head, right? That's going to sit in there and just stay quiet, and your immune system usually keeps it in check, so you don't get any additional infections. So where it sits is actually in your dorsal root ganglia. Remember we talked about that, where it's the big lumpy parts coming off the spinal column? Okay, so your immune system usually keeps it in check. However, should you become immunocompromised for any reason, there's a possibility that the virus will reactivate. And it reactivates along that dorsal root ganglia, along that single spinal nerve. And in so doing, will infect the dermatome that spinal nerve is responsible for. So here we see that this little stripe area of blisters is right above the belly button. If we go back to our dermatome map, we can see that it might have been, let's see, spinal nerve T8, all right, on the left side that reactivated. And that's why it forms this little stripe shape, okay, because it's the dermatome that's being affected. It's much more painful than chickenpox, shingles in general, and it causes these very painful blisters along the path of the nerve, okay, causing a lot of issues. It's more common after age 50 because you're more likely to be immunosuppressed or immunocompromised. And the chickenpox vaccine will reduce the risk of shingles later in life, but there is now a shingles vaccine. The reason the chickenpox vaccine helps is because it prevents this step, the zoster virus infecting your body, right? If the varicella zoster virus doesn't infect your body, it can't get into your spinal cord or into your dorsal root ganglia to become latent. It can't get in because it hasn't infected your whole body. If you do get the virus, however, it is possible for it to infect, which is why I think they say about 1/3 of people can develop shingles later on in life. Shingles is also not as contagious. However, if you were to infect someone with this virus here, you would actually give them chickenpox. So shingles can only come from your dorsal root ganglia, your spinal nerves, right? You can't give someone an infection in their spinal nerves. You can give them chickenpox that can later infect their spinal nerves, but you can't give someone shingles. Okay? Don't worry about that. We'll work on that in class. And last but not least, we will talk about reflexes. All right, so these are quick, involuntary reactions of your glands or muscles, right? Everyone's familiar with these. We live with them from day in or day out. Sometimes you don't even notice them. Like I said, one of the reflexes is that feeling that you have to pee or the feeling that you have to poop, right? Those are actually spinal cord reflexes that the stretch of your colon or your bladder sends a signal to your spinal cord, which shoots signal back to your bladder and your rectum that you have to go to the bathroom, okay? So it's automatic. You can't even control it. Of course, we also know some more common reflexes, like when someone jumps out at you, right? Your reflex, fight or flight, to run, and then the reflex that your heart starts beating very quickly, that sort of thing. Okay. So you have something called a reflex arc. And what that means is it's really quick, actually. So if you're doing a knee reflex, right? So the knee hammer to make sure that the neurons are working properly. What you do is, what you're actually doing is you're stretching this tendon in the knee, and that stretch triggers the neuron to go straight to the spinal column. The spinal column already has this like preset response, so it doesn't have to go to the brain and figure out what to do. It literally just goes, oh, I know this one, this is what you do. And it sends the signal back out to contract the leg muscle and kick the leg, right? So stretch is one of them. You also, oops, where's the other ones? There we go. You also have something called flexor or withdrawal, right? So if you step, or what happens if you stick your hand in the dishwasher and accidentally stab your finger on a knife, right? What are you gonna do? Are you gonna push your hand further? No, you're gonna pull it back, right? That's your withdrawal reflex. Cross extension is a little tricky. We'll talk about it in class. It's basically a combination if you're walking, right, and you step on something sharp, you withdraw your foot, but you also switch your weight to the opposite side of your body. That's the cross, right? So you withdraw your foot and you cross your weight to the other side of the body. That's the cross extension reflex. Okay, and then the tendon reflex. So stretch reflex is more specifically, it's kind of like a bladder stretches out. All right, something like that. Your stomach stretches. And that's a stretch reflex. Tendon is going to be the tendon stretches or is hit or, is tugged on. Like the tendon reflex you do with the knee hammer. Technically, that's the tendon reflex. All right, stretching is going to be more like bladder. Flexor is going to be withdrawal. Cross extension is going to be kind kind of like withdrawal of one limb and switching weight to the other. This might also work if you're, I don't know, um, playing on the monkey bars, right? And there's something, something's cold, so you, I don't know. It can also work if you're hanging, right? And you grab something with your one hand that's sharp, you pull that hand back, and you put the other weight on the other hand that's still holding on. Okay. Apparently, I really like withdrawal. Okay, so again, the reflexes don't go to the brain. It's a instant, nearly instant response from the spinal cord. Right, so it's literally just this loop right here, whoop, right around. Okay, so yeah, so those are your things. The last one we're going to talk about is something called proprioception. And proprioception is basically your ability to tell where you are in space and time. So this, for example, hand-eye coordination, being able to touch your finger to your nose, being able to stand up without falling over. A really good example is stand up, close your eyes, and try and stand there without falling over, or try and walk around a room that you're familiar with. Your proprioception is going to help you figure this out. Basically, you have muscles in your body that are designed to tell your body how long your arms are, right? How your arms are moving. This gets really screwed up when you're going through growth spurts, which is why people who go through growth spurts stumble and trip around a lot. Poor guys and girls. It's just kind of the way of things. Your body's proprioception just needs to adjust. Okay, this becomes a big issue with people who have neurodegenerative disorders. Proprioception is degraded in patients with MS because their body's attacking the neurons, so proprioception is weakened. So it's actually really dangerous, for instance, for someone with MS to take a shower because the act of closing your eyes to rinse your hair out causes you to lose balance and to fall over. So it can be really dangerous. So proprioception is actually really important to being able to function. Normally, we just don't notice it until there's actual problems with it. All right, so that's everything we're going to go over. I've posted a small quiz online on Blackboard for you guys to do. This will count as your quiz grade as well as your attendance. And I will be posting the homework as well. So I wish you all the best. I hope you have a great week. Everything will be due by next class. So have a good one. If you have any questions, please feel free to reach out to me either through email or I'll be in class and work this week. All right, have a good one. Bye.